Next, we have we're fortunate in having Mohammed Haskali. Mohammed is the king of radiopharmaceutical sciences, official title chief, but king is close enough. He's a rising star for Peter Mac, and his department is growing exponentially and appropriately so. Mohammed, thank you.
Thank you so much, Stephen. Where do I start? After returning back from a heavily regulated environment in the US, I kind of found the Australian radiopharmaceutical sciences framework quite vague and often, without consensus about standards of operation, and sometimes even delusional and out of touch, to be honest. So I thought the best way to start, perhaps, in this educational program is to tap into some of those controversies. I would like to make a head start, a humble contribution to understanding what radiopharmaceutical science is and how it works, and why does the actual controversy exist in the Australian radiopharmaceutical sciences framework. Just to be clear, this has nothing to do with clinicians. This is radiopharmaceutical practitioners, people that actually produce radiopharmaceuticals. So first of all, a bit about the historical context. I have been called a radiochemist, a radiopharmacist, and a radiopharmaceutical scientist. What is the difference? Okay, so historically, a radiochemist is a chemistry graduate that typically with a PhD that has had the opportunity to train under a practicing radiochemist in a hospital environment and who produces radiopharmaceuticals in a hospital environment. A radiopharmacist is one that is a pharmacy graduate that comes from the School of Pharmacy and typically has a master's degree and has also had training in radiopharmaceutical sciences. They're both trying to do the best for the patient, but they approach it in slightly different angles. A radiochemist looks at the making of radiopharmaceuticals as a manufacturing process where A and B are mixed together to make C. Okay? So he's very critical about the existence of A in the final formulation with C, and he's very critical of the existence of B in the final formulation of C. So he makes C, he wants to make sure he has separated A and B. A radiopharmacist approaches it from a pharmacy perspective. So they don't actually manufacture synthesized compounds. What they do in a compounding radiopharmacy is mix pre-manufactured compounds, mix it in different quantities to prepare a patient-derived dose. So that critical perspective, that synthetic perspective, is less prevalent in a radiopharmacist perspective. This led to a variation in skills and expertise, leading to a large variation in standards of operation. Okay? And they're both, like I said, trying to do the best for the patient. And what's interesting is that they don't like to work with each other. So if you've worked with radiochemists and radiopharmacists, they often do kind of qualitatively different things. However, the TGA exemption does not discriminate between the two. It gives them exemption to both operate and do precisely the same thing. Hence, the ACPSEM College, which is, I think, one of the best initiatives in our domain, came along and said, look, we're going to take specialist kind of professionals from chemistry background, pharmacy backgrounds, and different sciences backgrounds, and put them all through a uniform curriculum so that at the end of the day, it doesn't matter where you come from, okay, and what your previous training is, you now have a uniform training so that you can all operate to a similar standard. And hence, the radiopharmaceutical sciences title came through. So this, unfortunately, requires a lot of adoption of clinicians to adopt this new title and to actually embrace kind of radiochemists, radiopharmacists, whatever they may be, that have had ACPSEM certification. I think there is a long way ahead for us. And one of the criticisms, perhaps, of this is that in doing so, in bringing in mass kind of graduates and trying to all put them through this curriculum, is that what I've started to observe is almost the loss and the degradation of the esoteric dimensions of the discipline. You know, ones that actually used to be very prevalent. When a radiochemist spoke, he knew his stuff. Whereas when most of the radiochemists that come today, they just know how to make a dose, not necessarily understand exactly how it's made. So I wanted here to highlight again that the TGA exemption exempts hospitals that are not TGA registered, that are not GMP labs, to produce radiopharmaceuticals for public institutions, including their own. It is not an exemption from doing QC and quality control. This is one of the most controversial things that I've actually faced and which I find quite common sense, to be honest. Because the quality of a radiopharmaceutical, or whether it passes all the pre-release criteria, is a must. And it's a necessity before you can administer that thing into the patient. But what that requires is not only performing quality control, it's actually understanding the process. And this is where the esoteric dimensions exist. And here I have a case study, a chemistry case study. I know I like to freak people with my chemical structures, so I always put them in. So what you see there is a gallium PSMA structure. And what you see also with it is a HPLC trace that shows 2 peaks. And what you have in there are isomers. What isomers are in chemistry is, if you see my hand, okay, an isomer is the same hand, so one time it's pointing up, the other time it's pointing down. It is identical, but in relation to my body, it's different if it's pointing up or pointing down. So they can be separated. So isomers are chemically equivalent, but pharmacologically not equivalent. And so you need to understand this concept so that you can design your QC method to be able to separate them. I have seen so many HPLC traces where these two are not separated. And here again, what you see on the right is PSMA 617 as well, understanding that it undergoes cyclization under heat to generate this structure here. And it's important to know that because there is a very closely eluting peak, and if you haven't designed your quality control methods to separate that, you will never see it. So quality control is not this kind of black box where you put in every unknown and it reveals it to you. Quality control only tests for what you expect. So it only shows what you know. And so it's really important to approach it with a level of kind of extensive consideration and understanding. And so why is quality control essential? Thank goodness I don't make the rules. So there are pharmacopoeias, which are like the Bibles for the medicinal world, right? The pharmacopoeias provide standards of pharmaceutical substances and medicinal products. And the pharmacopoeias mandate quality control of radiopharmaceuticals for 2 distinctly separate but linked reasons, as they relate to pharmaceutical parameters and radioactive parameters. 1, the pharmaceutical parameters are designed to ensure that no microbiological, pyrogenic, or particulate contaminations can harm patients. The other is the radioactive parameter that is designed to ensure that the intended radiation exposure of patients is kept to a minimum by confirming that the radioactivity, radiochemical, and radionuclidic purity are assured. And based on this, really, I often hear about radiopharmaceuticals of high quality. And I kind of think, is there a medium quality radiopharmaceutical? Is there a low quality radiopharmaceutical? Not really. There are only 2 types of radiopharmaceuticals. One that pass all pre-release criteria and one that doesn't. And so the one that passes goes into the clinic and the one that doesn't is thrown away. It's discarded. So there isn't really a spectrum of qualities when it comes to radiopharmaceuticals. But there is, and I will get to that. And that has nothing to do with QC. It has to do with other things. I'll get to that shortly. So how are QC parameters decided? So how do we decide what those pre-release requirements are for a radiopharmaceutical? So they are basically decided using monographs, which are like chapters of a pharmacopoeia that highlight the actual methods of a QC for a given radiopharmaceutical. And when we do not have a monograph for a novel radiopharmaceutical, what we typically do, we base our assessment on the most relevant or the closest monograph to that product. But we also have some consensus documents, such as the Good Radiopharmacy Practice Guidelines and the Pharmaceutical Inspection Cooperation Scheme, PICS guidelines. Yes, you need to be GMP to conform to them, but there are still standards. If you're not GMP, they are the standards that you should always progressively work towards. And so it's really important that quality is not about a tick box where you say, yeah, I've done this and it's passed. Quality is about a state of mind. It's actually about a culture that you adopt in the lab that ensures that you're constantly and critically reviewing your processes to do the very best you can. And the very best is basically these guidelines. So they are at the pinnacle. And Yes, and so this is where we can talk about quality, okay? And just to reiterate, quality is not about the quality control parameters of a radiopharmaceutical. It's about everything else you do in the process to ensure that you've got the right facilities, that you've got the right equipment, that you've got the right record-keeping kind of practices, that you're selecting your starting material carefully, that you're training your personnel, that you have traceability, that you have processes, controls, and validations, and so on and so forth. All this, the quality assurance aspect of it. Sorry, Stephen, is this is saying how much more time do I have? Sorry, I can't see.
All the time you need.
Okay, thank you so much. So I'm just taking my time. It says 00, so I actually panicked. So did I just use all my time? Okay, so I'll just skip to the next slide. And here is the process validation. It's also important. I'm not going to go into it because I do think I am probably using all my time, so I'm going to make this a bit quick. So again, the process validation is a really important part of working up a radiopharmaceutical for the clinic. Historically, we just did technical runs, we labeled things, and there you go, it's ready for the clinic. That's what I do for my mice imaging studies. That's not what I do for my clinical doses. So for clinical doses, a whole process undergoes a thorough kind of process, which I don't have time to go into. And yes, I make no apologies. Making radiopharmaceuticals is an expensive business. You need the right infrastructure, you need the right personnel to make it available, and we can't take really shortcuts. And one of the most controversial things I've had is about, do we make radiopharmaceuticals on the bench? Because believe it or not, it still happens in many hospitals around Australia. And hence, I have this slide here. And what you see on the right there is Joanne Fowler, one of the kind of grandmothers of the discipline, really, godmothers of the discipline. And this is her picture making one of the first doses of fluorodeoxyglucose in 1976 in the Brookhaven labs. And in less than 50 years, a technological transformation led to these automated modules. The point of this slide is really that there is no way going back. Okay, moving forward, everything needs to be automated. And if you're not automating your processes, you're probably not working up to the standards. Automation enables scalability. It enables compliance. Radiation exposure to the operators is minimized, and the product is uniform with full traceability and reproducibility. And we've applied this to our lutetium kind of processes internally, and so we've developed this almost, I like to call a scalable universal kind of protocol using a multi-SIN module, which is a Melbourne-developed module, for those that don't know, by Stan, who also has a booth in here, so go and see him if you want to buy one. It's a great value for money module in comparison to many of its European analogs. In any case, we've designed this method to be able to produce lutate, Lu-PSMA-617, Lu-PSMA-INT, all using a uniform method with the same formulation and the same reagents, and also not by overcooking it, because I don't like my meat well done. So we always cook it under low and moderate temperatures that ensures that the radiopharmaceutical isn't broken to bits. And finally, we test our radiopharmaceuticals regularly, and every batch has a thorough QC controls, and these are some of the parameters that we assess and measure. And finally, I would like to end this talk by thanking the great team that I have that support me and my team, my direct team, the radiopharmaceutical sciences team in here, many of whom are included in this picture, and of course, Cancer Imaging's management, who were supportive of really the vision to transform radiopharmaceutical sciences at BRMAC. With this, I would like to thank you, Stephen, and end my presentation.